I'm a single researcher based at a Swedish university in a Swedish department. I love this place, but it's not a Sámi institution.
Welcome to the first episode of the Global Health Uprooted podcast. I'm Manas.
I'm Emma.
And the voice you just heard is that of our special guest for today, Petter Stoor, a clinical psychologist and researcher at Umeå University in the north of Sweden.
Deconstructing some of the colonial assumptions underlying global health practices is a process that has to start locally. For this first episode, we chose to focus on an issue that is rooted in the Swedish context.
The Sámi are one of the world's indigenous people and one of Sweden's official national minorities. They inhabit Sápmi, a region that stretches across northern Sweden, Norway, Finland, and parts of Russia. Approximately 20,000 Sámi, a fourth of the total community, currently live in Sweden.
Today, about 10% of the Sámi are connected to reindeer herding, a semi-nomadic activity which has often been at odds with the industrial ambitions of the Swedish state. Despite a warning issued by the UN human rights advisors, the government recently gave its approval to an iron ore mine project in the northern region of Gallup. In addition to disrupting a protected ecosystem and blocking the reindeer's migration, this project has shown the relevance of discussing Sámi health and rights through a decolonial lens.
This is why we reached out to Petter. Born and raised in a Sámi reindeer herding community, Petter's research focus is both personal and political. Aside from his academic work on Indigenous mental health, Petter has worked on behalf of the Sámi Parliament in Sweden and written a plan for suicide prevention in the Sámi community. We had a lovely discussion with him. We hope you'll enjoy listening to it. Hello and welcome to our podcast. We're so happy to have you here. So to start off, could you please introduce yourself, your research area of interest, and what got you into it?
Right. My name is Jon Petter Stoor, or Pikkunils Antipietar in Sámi. So I am a Swedish and Sámi clinical psychologist by training. I grew up in the northernmost parts of Sweden in a town called Kiruna. My family belonged to the Lavas reindeer herding community, which has their reindeer herding grazing lands around Kiruna and the huge iron ore mine situated in or just outside Kiruna. And for the last 10 years, I've been working on Sámi health issues, development projects and research projects, and mainly focusing on mental health issues and suicide, and especially mental health and suicide among young Sámi guys. Now I am a postdoctoral researcher at epidemiology and global health at Umeå University, and also a researcher part-time at the Center for Sámi Health Research at UiT, which is the university in Tromsø in northernmost Norway. We're conducting some cross-sectional Sámi health surveys that we're really excited about.
Thank you for sharing a bit more about your background. So on the topic of mental health, Manas and I were really curious to hear more about the report you recently published, giving some policy recommendations for suicide prevention in the Sámi community. So could you tell us a bit more about what you consider to be important determinants of mental well-being that are specific to the Sámi community?
So that report came out, I think it's 5 years ago now. And it's the suicide prevention plan for the Sámi people in Norway, Sweden, and Finland. All of these countries, Sweden, Norway, Finland, they have a welfare system that is inclusive and inclusive of Sámi as well. So lots of things are probably working really good for Sámi. But the focus of that report was to highlight from a Sámi perspective what issues coming from research seems to stand out or is not properly fulfilled or dealt with from a Sámi perspective, and also from this perspective of suicide preventers. You could call them grassroots. What issues do they see and what issues do they want to highlight? And actually we start out by pointing at how little we know. There's not been that many research, although mental health has been, I think, the primary focus of Sámi health research, at least in Sweden. But there's so much we don't know. So for example, when it comes to suicide data, so actually completed suicides, we have data in Sweden from 1961 to the year 2000. So it's more than 20-year-old data by now. And the situation is similar in Norway and Finland as well. So that's a huge obstacle, obviously. But what we know from those, it's 3 cohort studies. What we know from them is that the Sámi men have tended to die more often by suicide than they should have, according to the majority population data.
That is very interesting to hear. I was wondering, what do you think about how gender and ethnicity intersect specifically among Sámi men to, determine mental health and mental well-being? Do you have any thoughts on that?
Yeah, I think I have 1,001.
Go ahead.
Well, it's super interesting that is the case. It's tragic, of course, also, but it's interesting too. And it's interesting from a Swedish Sámi perspective. I think it's interesting mainly because that connects to the pattern that we see worldwide in indigenous populations, where we're also seeing the indigenous men, and especially the young indigenous men, dying by suicide at much higher rates than they should. So there's something going on there. Maybe you could say that there are crashes in the intersection between being a young indigenous man and growing up and living a healthy life and have good mental health. On the Swedish side, it seems to be mostly present in the reindeer herding population, actually, which is also interesting because the reindeer herding Sámi population in Sweden, that's the population that has most access to the factors that we think are protective from a Sámi perspective. So they are engaged in Sámi culture. They often speak the Sámi language. They have Sámi networks, etc., and strong identity. So things that should promote good health, and especially good mental health. And although that is the case, we're seeing among that particular population this overrepresentation. How can we explain that? Well, one hypothesis would be that maybe these guys aren't as strongly connected to the majority society as the young women may be, because that may also be a protective factor. Of course, it's good to have a strong sense of who you are, your cultural identity, etc. But it's also really good to be connected to the majority society, to get an education, get a job, all of those things, and get a network that is outside of your indigenous community. And it may be that the guys don't get that to the same extent as the girls.
That's super interesting, and it makes me think about one of the points you highlighted at the end of the report, that most suicide prevention initiatives tend to focus on the individual level. And for the case of Sámi youth, maybe more like community level determinants might be at play, and it's a missed opportunity not to target those as well. In the report, you also mentioned the lack of robust data on suicide among the Sámi. This is in particular due to the fact that ethnicity is not registered among the common data collecting procedures in Sweden. So we are interested to know what are your views on this decision.
Well, it's interesting because we have really good register-based systems in these countries. Northern Sweden and Finland really stands out internationally with really robust system, and we have unique person numbers, identifiable personal numbers connected to all kinds of registers, including the mortality register. So we could easily get an idea about the situation when it comes to suicides in particular age groups, in particular parts of these countries, etc. But we cannot get an idea of how does this look like in relation to ethnicity. And I think the reason for that is because we do not include ethnicity because it was connected to race. And that is what we really don't include in the Nordic countries when it comes to registered data. It's prohibited to include race. Ethnicity, we can use that concept in research, race too. But this is the reason why we only have research data. As I said, there are 3 cohort studies. You cannot contact the Swedish Statistics Bureau and ask for a withdrawal of, okay, so how many Sámi suicides do we have? They have no idea, and no one does unless we produce research on it. It's really an obstacle when working with Sámi health issues and with suicides among Sámi. It's very problematic. And then you have the Swedish history, and the Swedish and the Nordic states history, and the European history. And of course, this is connected to the Holocaust and the Second World War. And there are good reasons, or there were good reasons to kind of abandon the racial category. But from a Sámi perspective, if states acknowledge that there is a Sámi people and that the Sámi people have a right to work on and improve their society, including health issues, how can you do that if you do not have data? And it's not like the Swedish state, at least, has really come to terms with this or kind of seen this, the lack of data, because if you do not allow for registration of Sámi ethnicity in the registers, okay, then you must seek other ways to get that data. But we're not producing a lot of research on Sámi health. So we don't have any institutions that are tasked to work with this. We don't have any specific research calls. So it's just kind of left. And that is problematic. I mean, there can be different solutions to this, but there can be no solutions unless there's resources. And at the moment, there really isn't, at least not dedicated resources.
No, that's definitely a very important issue to point out. Like you said, they may have had origins in, or like the thinking may have been to prevent discrimination by preventing specific identity to be registered. But now that kind of obscures the issues that the community is going through and allows for like no advocacy or research to happen, really. Considering this, I was wondering, how was this list of recommendations that you published 5 years ago, how was this received?
Well, in the mainstream health science or medical science, Sámi health science is such a minor part. We're such a small fringe group of people that it's not necessarily so that people will reach out to us or feel that, okay, this concerns us. So it's a kind of a comfort to be part of international systems where we have more interested colleagues to whom to talk to and advance ideas, etc. I think on the state level, actually, we have seen this document being used. It's being referred to in the new Norwegian and Finnish national plans for mental health and suicide prevention. And we also, Sweden is on the verge of producing another volume of that as well. That's going to come in 2023. And they are including the Sámi Parliament as part of that process. And I would like to think at least that our document kind of paved the way for that. So at the state level, I think it's being used as a kind of a policy information tool. And that's really good to see. The academic world hasn't really responded to it, I wouldn't say. And then we have the Sámi. I think from a Sámi point of view, it was a very useful document. It has been and is still, I think, an issue of, suicide then. Suicide among Sámi is still an issue, has been for 15 years perhaps. Health isn't that much of, it isn't something that is commonly debated in Sámi politics, for example, at least not on the Swedish side. But when it is, I think mental health is at the core of it. So it's super important to provide reports also for politicians to have something to work on, something to kind of dig into, and something to, okay, so this is an issue that we have to deal with, or this is how we want to deal with it. And those 11 strategies that we have in there, they may point the direction in certain ways and help inform a political dialogue, I think.
And as you said, like the first step to having this policy formulation is having data and having a solid evidence base.
Yeah, so or at least something. At least something. I wouldn't call it really a solid evidence base. That I would, in my dreams, we would have that. But it's what we have. You know, we have to just somewhere you have to start, and this is where we're at. And and we cannot start somewhere where we're not really. So we just have to put it out there. And it is flawed. There's so much we don't know. We have cross-sectional data from here or there or that subpopulation and we don't have any national data, etc. So there are certainly drawbacks, but it's what it is.
Yeah, like you mentioned earlier, I think you said you were currently working on some cross-sectional studies as well. So I guess, researchers such as yourself, the entire responsibility to produce data falls on you when there is no centralized system or a dedicated center or something to produce systematic data. But yeah, hopefully that can be something that changes in the future.
Yeah, and to be fair, also we're seeing more and more interest from the states. So the public health agency in Sweden, we have contracts with them now, and so we're working on issues that they want us to work as well. And that goes both ways. So now that they have contracted us, of course, we're going to report back to them, and we hope that will lead to new research avenues. So things are happening, although quite slow, and it's 2021. We should have, or 2022 actually, we should have gotten further along this road by now, but we have not.
So thinking about these research gaps, how do you see the role of the Sámi community in this process of gathering more evidence to inform future policies? How does that differ from studying the health of the general population?
I think it's interesting that the survey that we sent out, we got almost as good response rate as the Swedish national survey. So it's obvious to me that Sámi want to participate and they want to know their health status. That's for sure. On the other hand, I think there's too little information out there. I think people are not enough aware of this issue, and it makes it hard for them to grasp in what ways they can kind of promote the issue in itself. At least if you look at the Sámi politics, as I said, their health, it may be on the agenda, but it's it's not the most prioritized issue. And I think that's partly at least due to lack of information, lack of data, lack of debate. In a dream world, I would hope for the Sámi politicians and the Sámi society to really, let's say this is important and we want data and we want to be able to work on this, and kind of a bias for us would be the dream. And that is in lots of indigenous communities, you have much stronger institutions, indigenous institutions working on their own health. We don't have that.
I'm very curious about what you just said in terms of other indigenous communities across the world having some stronger institutions. You said partly one of the reasons why that isn't the case here might be the lack of information. Do you think there are any other important factors to why there may not be that kind of strong institutions?
Yeah, I think there are, but I think when we're looking for reasons why we lack these institutions, we should not look necessarily at the Sámi society, but at the society at large. Because in the Swedish system, for example, you cannot establish an institution if you haven't the funding for it. And the Sámi institutions that we have, they're not allowed to tax citizens, for example. So they don't have sources of income to found institutions should they want to. They're always dependent on the states or majority society institutions to kind of support them. So we should be looking there to find the explanations why we're lacking the things we are. And it's complex in many ways. I mean, we have indigenous systems and indigenous institutions in some other parts of the country and some other parts of the world, and also in the Arctic. We could look at Greenland, for example. Formally, they are a self-governing territory, and they have lots of possibilities then, obviously, to create institutions, and they have their own university, and that university has a health and social department, I think, and a Greenlandic Health Research Institute. They also are limited by funding, but it's not necessarily so that the places that has the most institutions are the ones that has the best health outcomes. Rather the opposite, it seems. If we compare Sápmi with Greenland, for example, the big picture is that there are more health problems on Greenland than in Sápmi, although we lack specific Sámi institutions to support the Sámi. So it's complex. It is connected to the political and to the colonial histories. Sámi are a very small minority in Sápmi, in our traditional lands, whereas the Inuit of Greenland, they are a majority, but they have more health issues. So it's connected to the histories and colonizations of these areas.
It's absolutely correct to, I guess, view this issue as much more complex than a lot of health issues are made out to be. A lot, like you said, a lot of mental health issues are individualized in popular conversation, and there's so much about the wider structural issues and especially histories, colonial histories, especially of Sweden with the Sámi community, that inform how institutions or lack thereof look today and the health status looks today, or the inability to examine the health status looks today. Yeah, that's very interesting.
I guess bringing in the comparison of Greenland into the discussion made me think about one of the recommendations you suggested, to consider these problems in a cross-border perspective. And I was curious to hear your thoughts on self-determination and cross-border strategies. Do you think that that could be a promising avenue for addressing the problems of the community?
Yeah, I think so. I guess for two reasons. And the first is that there are limited resources. Even if we would have more, there would still be limited resources. And it makes sense to pool what we have with the Sámi on the Norwegian side and Sámi on the Finnish side, at least. The Russian side is, for many reasons, very different. And present with the war, it's just not possible to cooperate, really. But the lack of resources, then it makes sense to pool it, right? And also it makes sense to pool it because if we do, we may get an institution that has a Sámi perspective. I'm a single researcher based at the Swedish University in a Swedish department. I love this place, but it's not a Sámi institution. When we pool resources like that, what we get is a kind of, maybe we could get across the threshold of building something that is coming from within the Sámi world and having Sámi priorities. And that is what we're lacking, because we have lots of good things. I mean, the mental health systems that we have in Sweden, Norway, Finland, they're great if you compare it to other places. But what they're lacking is the specific Sámi components. And how to get them? Well, then it's not necessarily best to have single individuals at the public health institutions in Stockholm or in Umeå. We may have to gather the Sámi to come up with these specific solutions that concern only the Sámi. So to get that, I think it's important to build a Sámi institution. And that is perhaps only possible when looking across the border. So two arguments, resources and the specific Sámi things.
Tying this in with the discussion we just had about colonial histories and how they shape the present, it's very interesting to see how, a lot of colonial history has been focused on drawing borders, especially in, a lot of European nations going to lands that are already inhabited and kind of drawing arbitrary borders to create these very closed off nation states. And now we're more and more seeing that these very nationalized structures, which were created 300, 400 years ago, are not going to serve us anymore in the future. And a lot of more collaborative, like you mentioned earlier, grassroots efforts are needed to decolonize in some ways.
To bridge the borders that others set for us.
Yeah, exactly.
Yeah, I think so.
It's quite ironic that the discipline that we're all a part of is called global health, but there's still such, minimal recognition of collaborating across borders. That really needs to be a priority in some ways.
Sure. Well, but to me, speaking of that, I mean, one reason I thought so this is really an interesting conversation to be part of, because I'm part of a department of global health, but I don't see myself as a global health scientist. I'm a Sámi health scientist, and I work with my community that is quite close, or even just outside here. This is Sápmi too, where I am based. So it's super interesting that you're, as global health students, take interest in the Sámi health issue, because you're coming from this, I would guess, from a global health issue, and then, or from a global health perspective. It becomes interesting because you're trained to look at things differently than, the medical students that we have here, right? So it would be super interesting to hear about your take also on, so what were your thoughts when you kind of discovered the Sámi health world?
I think for a lot of us, I mean, we are technically public health students based in the global public health department of a biomedical university. So for us, it was like we have to, go out on our own looking for a lot of perspectives that are missing in our classroom. And that is kind of, I think, what led us to Sámi Health and trying to look at more of the social, societal, historical determinants of health.
talking about building bridges and crossing borders, I was interested like how might that apply to like doing research, like and the type of methodologies we use, like how you think we could make room for other types of knowledge and other methods that could be more culturally relevant to other communities.
Well, I think that's a challenge when doing quantitative research, because we're basing so much on what we do from what has been done. It's a bit easier in qualitative. I'm a qualitative scholar, actually, rather than quantitative, I would say still. And in qualitative science, it's okay, if you want to investigate the particularities, then go ahead, do it, dig. In quantitative, I feel it's more that we're part of a system, and these are the methods, this is the set of methods. And if you, for example, if we take the survey that we have conducted as a kind of an example, for us, it makes great sense to build it or construct the survey that we do from the national Swedish survey. We want it to be usable, operable data. And for it to be usable, it has to be comparable with the Swedes for it to kind of have value within the Swedish system. But of course, the questions that are included in the Swedish National Public Health Survey is not built on an understanding of what health is from a Sámi perspective. There may be other issues, right, that the Sámi would have liked to highlight. And we have tried to accommodate for that a little bit, or we tried hard, but it's not that easy, at least not at this point, I think. And the issues that we, in the end, were able to include as kind of extras, they're more areas where we think there may be extra problems among the Sámi, rather than, say, areas that the Sámi see as central to their health. That may have been more, what about hunting? What about berry picking? What about traditional practices? That's not in our survey. It isn't. Maybe it will be in 5 years or in 10 years, but it's a slow process. And since we're building on something that is essentially a Swedish survey that is then also connected to international surveys in other Western countries, we're working from something that is essentially non-Sámi and trying to adapt it slowly to something that is useful from a Sámi perspective.
Yeah, and I'm assuming it's very hard to work within these rigid structures, especially in quantitative methodology, that you have to follow to be considered, scientific or valid knowledge. And you have to really slowly make these changes, because every change is still being viewed from a Swedish perspective and from a Western scientific perspective.
I think so. A great example would be statistical significance. In the Arctic, we have small indigenous populations. There are small societies. Even though suicide, for example, is regarded as a huge problem among the Sámi, there may not be that many suicides. And since we don't have that many suicides, maybe there isn't statistical significance to show that this is statistically significant, a larger problem among the Sámi than other populations. While still, from a Sámi perspective, this is of huge concern. It's an Arctic indigenous problem when we use methods that are developed elsewhere for other kinds of populations. But we're also forced to use those methods because as scientists, we're publishing in journals based elsewhere. They're not Arctic journals, right?
And it's quite a hard line to tread as well, like reconciling the need to make your results like intelligible to a wider community and to advocate for more resources and awareness, and then the other having these tools that are not suited to the type of problems and the communities that you are actually trying to advocate for. As we near the later part of our discussions, what do you envision for the future, like when it comes to research and policies? What are the type of changes that you would like to see in the future?
Well, I think so. Looking at this from a kind of a really top-down perspective, Sámi health in relation to health in the Nordic countries and also perhaps in relation to global health issues, Sámi are really good off. We're lucky. Among the indigenous populations, we're among the lucky ones. And that is, I think, connected to the Nordic welfare system and how that has, for all of its flaws, how it has been able to be inclusive of the Sámi. However, the specific things that are important in the Sámi culture and in the Sámi societies, they are kind of rendered invisible. And so, for example, working with this survey to make it really relevant from a Sámi perspective, not from a Swedish public health perspective, but from a Sámi perspective, that is super interesting to me. What does that mean? And that would be really exciting. And I think we're seeing the same kind of development in other, at least in the Arctic, and where I have most knowledge about what's going on. My colleagues in working with other indigenous Arctic peoples, they're also interested in the same thing. So I think that we'll be going in that direction, looking at specificities more.
That's really fascinating to hear. I'm wondering if it takes a lot of imagination and creativity to kind of even envision a world that is not centered on a Western Swedish perspective and is more, relevant to Sámi health. Do you find that kind of easy to imagine what that kind of a global health research landscape or just health research landscape would look like?
No, I wouldn't say. And that's why it's important that the influences that you get, other people that are interested in the same kinds of issues, that you need to kind of take care of that, connect to them, talk to them, because it's not mainstream. But even in a place like Swedish academia, where this is really outside the mainstream, there are glimpses and there are other people interested in the same things. And there's always this international global community that you can also connect to. So that becomes more important, and try to seek out those ways of working together is super important, I think.
Tying back to our earlier points about cross-border collaboration, I guess seeking out people who are interested in the same things and collaborating is one of the key things that I think at least I've taken away from this conversation, to kind of keep the momentum going and to have at least the community to envision a future together that is different.
And that is I'd say that the energy to do that, it comes from two ways. Partly it's the global, the international, it's the academics, but it's also international organizations, indigenous organizations that work on the international level. And then it's also in the community. Okay, so you want to find out what to ask about Sámi health? Well, you have to talk to people. You have to be in the community. So it's on the highest kind of global scale, but it's also on the very, very local. And that's also super interesting, both those places and how they connect, because they do. In my experience, they really do. You go to local indigenous communities across the globe and you'll see similar kinds of issues. In the Arctic, obviously, lots of it is connected to climate change at the moment. But 5-10 minutes into the conversation, you're going to start seeing how things connect.
Connecting locally and globally is very vital to this, it seems. Anything else to add, Emma?
Yeah, I guess just like the two-way process you just described highlights how important it is to have Sámi voices also within this field of research, because I think that you are like the best situated to advocate for all the issues we just discussed.
Absolutely, but you also need the kind of the interpreters. You need the go-betweens.
Yeah, we need both, I guess, centering voices within the community, but with the help of translators and interpreters, as you said, who are also invested in the same things as you are. Again, collaborating not only with indigenous voices across the globe, but hopefully allies as well.
And within the other parts of academia.
Yeah, 100%. I think that's quite a positive note that we've led our conversation to, more about collaborating and envisioning a future together that is different, as opposed to kind of resigning ourselves to working within current structures. This has been a fantastic conversation. Thank you so much. Any final words you'd like to add for this conversation?
Thanks for having me.
It was
fun.
Yeah, thank you so much. This has been an amazing conversation. Hope this was amazing for whoever is listening as well in the future. Thank you so much.
Thank you.